So this is an 82-year-old monocular white female with geographic atrophy who presented to me concerned about their right eye. Unfortunately, their left eye has hand motion vision from a previous bout of endophthalmitis related to a glaucoma surgical procedure that they had years prior. This is the patient on OCT at baseline. I want to show both eyes just to highlight how high stakes the scenario is. You can see in the right eye, the patient has relatively good foveal preservation with areas of geographic atrophy that are readily apparent on the near-infrared reflectance image. In fact, if we pause right here, we can see areas of hypertransmission defects that correspond to the areas we see on NIR. Versus the fellow eye, we can see what is amounting to a disciform scar, significant distortion of normal foveal and retinal anatomy. And so we can see that this patient really only has a good functioning right eye. But that being said, don't let the visual acuity fool you. This patient sees 20/30, but the stories on infrared reflectance as well as OCT and fundus autofluorescence tell a different story. And this patient is at high risk for GA progression. Knowing what the risk factors are, knowing that the fellow eye status is somewhat limited, the patient was motivated to start on complement inhibitor therapy. And so the patient received their first injection of IZERVAY, and you can see them at follow-up. Vision is about the same, 20/25, and the OCT looks vanilla. This patient understands what the assignment is. They understand what their goals of care are, and they are motivated to continue treatment with IZERVAY. They feel like the injection wasn't as bad as what they expected. They feel less helpless because they are taking an active role in their care. And so the patient continued follow-up with another injection. Pictures thankfully look similar as well. And so when a patient looks at their autofluorescence image and they look at it today versus 6 months ago or compared to baseline, they can pay attention to the subtle changes that we're seeing that are more obviously highlighted on that fundus autofluorescence image. Patient continues for follow-up, and again, we see relatively well-preserved acuity on the Snellen chart. We see the NIR image and the OCTs show relatively well-preserved retinal anatomy at the fovea and parafovea regions. The patient is locked in for treatment, and so they continue on at about every 2-month cadence. And so now we're a year in, and we see that thankfully the vision is still in that 20/25-20/30 range. The OCT looks very similar to baseline. If you look at the far right at 12 months and the far left, there has been some progression, but thankfully the progression hasn't been closer to the foveal center point. We cannot stop it. We are taking the bull by its horns. We are being proactive in treating disease. And this is a motivated patient who likes to look at their progression, who likes to look at their images, and ultimately who likes to know that they are taking action by treating their geographic atrophy.